Welcome to this medicine masterclass in which we will be discussing a case of aortic stenosis. Aortic stenosis is a narrowing of the aortic valve, restricting blood flow from the left ventricle through into the aorta. The symptoms classically manifest as exertional dizziness, pre-syncope or syncope, dyspnea on exertion with a decreased exercise tolerance, as well as exertional angina. So let's take a case. Mr. Jones presents with exertional dyspnea, perform a cardiovascular examination and have a case-based discussion. Present the findings by using an inspection, palpation, percussion, auscultation approach in the same style of examining the patient. On inspection in lone aortic stenosis, the precordium would appear normal with no scars. On palpation, the apex beat would be found to heave. That's as a result of increased myocardial tissue responding to the increased pressure due to aortic stenosis. The apex beat would not be expected to be displaced. It would be found in its usual anatomical position, the fifth intercostal space, left midclavicular line. And a precordial thrill, that's a palpable aberrant jet of the murmur, would be palpable. Percussion's not relevant in the context of a cardiac examination. On auscultation, heart sounds 1 and 2 would be present, but S2 would be split. Now, S2 consists of two components, the aortic and the pulmonary component. The left side has higher pressure and more myocardial and electrical tissue. As a result, the aortic valve closes very slightly before the pulmonary valve, and hence we denote that as A2, P2 in chronology. But any activity that delays the ejection of the blood from the left ventricle will also delay and consequently result in a splitting of that A2, P2. So initially there's a widening of the split, and then finally a reversal of the split where the pulmonary component closes while blood is still being ejected through a stenotic valve. Other conditions that delay the closure of the left-hand side, such as a left bundle branch block, will also split. Comment on the key murmur characteristics found in aortic stenosis. Grade the murmur using the standard grading system. This is grade 1 to 6. Grade 1 is a very faint murmur which may only be heard by an expert or not at all and only picked up on echocardiography. Grade 2 is soft, heard in all positions, but does not have a thrill. Grade 3 is a moderately loud murmur without a thrill, and grade 4 is a loud murmur with a thrill. 5 is a very loud murmur which can even be heard with the stethoscope partially off the chest. And a grade 6 murmur is where the murmur is very loud, a thrill is present, and can be heard with a stethoscope entirely off the chest, just over the precordium without touching the precordial skin. The murmur is described as an ejection systolic, crescendo-decrescendo murmur, best heard in the aortic region, accentuated with the patient leaning forwards, as well as in expiration, and the murmur radiates towards the carotids. Now, any maneuver that will increase blood flow over the aortic valve will increase the turbulence and subsequently the intensity of the murmur. So expiration will increase left ventricular filling, will increase the blood flow through the aortic valve and will increase its intensity. Leg raising and squatting will also increase venous return to the heart, will increase cardiac preload, increasing the blood flow through the valve, and will also increase the intensity. Leaning forwards will cause the valve to be closer to the precordium, making the murmur more audible. We mentioned that the carotids should be auscultated, assessing for signs of radiation. In more advanced aortic stenosis, the murmur may radiate throughout the whole of the precordium, and this is known as Gala-Vardin's phenomena. And this may be louder as the disease progresses. Other peripheral signs associated with aortic stenosis, you'd expect a regular pulse. However, the quality of the pulse and the character would be described as slow rising as the blood slowly ejects through a stenotic valve and would be subsequently relatively delayed. And this is known as pulsus parvus etitis. It would be low volume as a consequence of the stenotic valve, and you'd expect a narrow pulse pressure in more severe aortic stenosis. The JVP would be expected to be normal, and in lone AS, you would not expect any peripheral edema. So putting all of this together, you could suggest that Mr. Jones presents with shortness of breath, comfortable at rest, and I believe that this patient has signs consistent with aortic stenosis. On examination, the precordium appeared normal with no scars, the apex beat was not displaced, palpated in the fifth intercostal space left midclavicular line, and was heaving. On auscultation, heart sounds 1 and 2 were present, S2 was soft and reverse split, and I auscultated a grade 3 ejection systolic crescendo decrescendo murmur, heard loudest in the aortic region, radiating towards the carotids, accentuated with the patients leaning forward and in expiration. The murmur was heard throughout the precordium, particularly over the apex, and this is known as Gallivan's phenomena, and I noted that the pulse was low volume as well as slow rising and delayed, known as pulsus parvus etitis. This would allow you to move on to the causes. The causes of aortic stenosis include age-related degeneration, calcified degeneration of the aortic valve, and in some patients who have a congenital bicuspid rather than a tricuspid valve can also develop stenosis. Rheumatic heart disease, which is becoming rarer, congenital heart disease, and infective endocarditis can also result in aortic stenosis. So what are the differentials? Systolic murmurs, ASS and misses is the mnemonic, so aortic stenosis and aortic sclerosis, and the corresponding valve, so pulmonary stenosis, would also give a similar systolic picture. Mitral regurgitation and tricuspid regurgitation are also systolic murmurs, and mixed valve disease would also result in a systolic murmur. Just be aware that the difference between sclerosis is usually seen in elderly patients, the pulse volume is not affected, and the murmur does not radiate, and sclerosis essentially means a hardening of the valve, whereas stenosis refers to the narrowing of the valve and would result in a reduced pulse volume and a murmur that radiates. The features of a severe aortic stenosis would include a narrow pulse pressure, a soft second heart sound, reverse splitting, a heaving apex, and eventually cardiac failure. The complications of aortic stenosis would include heart failure, pulmonary hypertension, can result in sudden cardiac death, particularly through the precipitation of anemias, and the abnormal valve can develop endocarditis. Importantly, there is an association with a bleeding tendency, and this is known as Heyde syndrome. In Heyde syndrome, there's an association of aortic stenosis and chronic gastrointestinal bleeding. And this is because inactive von Willebrand factor, which circulates around in a folded form, when it encounters the turbulence of the jet from the aortic stenosis, causes unraveling of the von Willebrand factor. Now, as this is not required, the von Willebrand factor is degraded by a natural enzyme called ADAMTS13. Consequently, the overall quantity of von Willebrand factor reduces in the blood, and so that increases the propensity of bleeding and results in angiodysplasia, and patients can present with symptoms of upper GI bleeding, such as melena. How do you investigate a patient with aortic stenosis? They would require bloods, so a full blood count looking for signs of anemia or low platelets, U's, clotting for a surgical workup, glucose looking for signs of diabetes, and if there's any indication of endocarditis, they would require serial aerobic and anaerobic blood cultures. An ECG would help you determine whether there's any end organ damage to the heart, signs of left ventricular hypertrophy, which would be evidenced by left axis deviation. You may be able to detect any arrhythmias, and whether or not there's any signs of heart block. Particularly with calcific degeneration of the valve, that calcium can also deposit in the AVN and the SAN, resulting in heart block. A chest radiograph would allow you to look at the heart valve, looking for any signs of obvious advanced calcification. But importantly, the echocardiography is the key investigation of choice. In AS, with normal left ventricular systolic function, symptoms usually occur when stenosis is very severe. That's when the valve area reduces to less than 1 centimeter squared, or the aortic velocity increases. When it's more than 4 meters per second or higher, the patients would generally develop symptoms, or whether the gradient across the valve exceeds 40 millimeters of mercury. Other investigations would include cardiovascular magnetic resonance, which would allow you to look at the shape and the size of the aortic sinuses as well as the cardiac structure in more detail. And any patient who is being worked up for cardiothoracic surgery should have a cardiac coronary angiogram to see whether or not they would require a coronary artery bypass graft at the time of surgery. And that leads into management. So again, patients should be managed holistically in a patient-centered approach using a multidisciplinary team, and the options available are conservative, medical, interventional and surgical. Conservatively educate the patient and address any psychological concerns, advocate smoking and alcohol cessation, weight loss, optimize comorbidities, offer fluid restriction as a measure if there's the development of heart failure, and provide advice to contact the BVLA, particularly if they're developing symptoms of syncope, and prepare the patient for surgery if indicated. Medically, it's important that you optimize comorbidities and treat heart failure if it arises, and consider beta blockers, particularly if they're developing arrhythmias, and if they develop endocarditis, then that would require aggressive treatment. The surgical options, we could follow the European Society of Cardiology, the ESC, and the EACTS, or the European Association of Cardiothoracic Surgeons, joint guidelines for the management of heart failure. Importantly, we determine whether or not the patient is symptomatic. If the patient is symptomatic or has signs of heart failure and they're a low-risk candidate, they should be offered surgical aortic valve replacement, or if they're a high-risk patient, consider a transcatheter aortic valve implantation, and if they're asymptomatic and they have a preserved ejection fraction, they can be reviewed in 6 months. The options are tissue valves or metallic valves. Tissue valves last around 10 years, and the advantage is they don't require anticoagulation and can be used in elderly patients. Metallic valves last much longer, 30 plus years, but they require lifelong anticoagulation and currently require warfarin therapy, and these can be used in younger patients. A TAVI, or a transcatheter aortic valve implantation, is a percutaneous procedure, and this is used in high-risk cases, and this aortic valve can be delivered through a femoral route or a transapical route, as well as a subclavian or a direct aortic route. In summary, we've discussed the case presentation, the signs and symptoms associated with aortic stenosis, the differentials, the investigations, the management and the guidelines, and how to discuss this in a case-based discussion. Thank you for attending this medicine masterclass.